right. Well, everyone, my name is Christie Morrison. I am one of the nurse practitioners. I work with Oshi Health and also TDDC, which is a clinic that is part of the GI Alliance, larger community for GI practices. And I am going to be talking today about MASLD and MASH, and we're going to be talking about some lifestyle modifications that can be used to help our patients with these conditions. I'm going to go to the next slide. Awesome. So we're going to jump into a case study where we're going to review a patient who has some risk factors consistent with MASLD MASH and talk about some recommendations that we can use for him to hopefully help decrease this disease burden. Next slide. Next. Next. I think you guys have already joined, so we don't need to use this QR code. But if you visit this MASH Community Network site that is sponsored by Madrigal for education and this promotional program. So let's get into our case study. We've got Albert, who is a 65-year-old male. He has a history of obesity. He's been referred to us in our practice today for elevated liver enzymes, and he's already had some abnormal imaging that was ordered by his PCP that shows that he's got some increased echogenicity, which we believe is consistent with steatosis or fat in the liver. When we take a look at the labs that were already completed, we see that he does have normal triglycerides at 89, but his HDL is 41. However, he also has a hemoglobin A1C of 7.2%. He's got elevated ALT for the past 3 years. Usually it's within 1 to 2 times the upper limit of normal. And he's already had a lab workup to rule out other conditions that could cause chronic liver disease, such as autoimmune diseases and infection. When we go through his medical and social history, we see that he does have a history of type 2 diabetes with high blood pressure and known hyperlipidemia. He has not drank any alcohol since his early 20s. And on physical exam, we see that he does have some increased abdominal girth, but no stigmata of advanced liver disease, such as a distended firm liver. We're not seeing any angioectasias or any jaundice. And we calculate his BMI is to 29. Next. So what do we think this diagnosis is? Metabolic dysfunction associated steatotic liver disease, which we're now calling MASLD. So what do we do first to really evaluate the degree of MASLD? We want to use our non-invasive testing to calculate a FIB-4 score. When we look at his ALT, AST, and platelets, we can use a calculator to determine the FIB-4, and we see that his FIB-4 score is 2.22. So based on that score, we've determined that he is an intermediate risk for fibrosis or advanced liver disease. So how can we best determine if he has any degree of fibrotic liver disease related to his steatosis? We can do further non-invasive testing as well. And we can do this through a variety of different ways. We can try a FibroScan, we can use an ELF score, or we can use an MRI elastography to evaluate the stiffness. For him, we decided that, next slide, or if we can go further in. So since we've just determined that go back one more. Since we've determined that he's an intermediate risk, we did decide to do a FibroScan for him, which shows that he has a 6.7 kPa. That's his liver stiffness score. And that shows that he's low risk based on the liver stiffness scores of less than 8. Anything between 8 and 12, he would be considered a moderate risk, or greater than 12, he would be considered high risk, and we'd want to refer him to a transplant hepatologist. So based on that low risk of liver stiffness score, we determined that he's not in danger of needing any significant aggressive recommendations for treatment right now. So we want to focus on lifestyle modifications, and we really want to manage his overall metabolic diseases to include his hyperlipidemia and known diabetes. And then we're going to have him follow up with us in about 6 months to repeat those non-invasive testing again. Next. So for him, we have a couple of different risk factors here. We know when we're looking at MASLD, we consider things like weight, type 2 diabetes, or a combination of 2 or more metabolic dysregulations. When we have fatty liver disease, it leads to steatohepatitis, or inflammation in the liver, which causes MASH. And then both MASH and fibrosis can lead to cirrhosis of the liver. So this is not something that we want to just send him on his way and never bring him back for monitoring. We want to counsel him now to hopefully prevent that progression to both steatohepatitis and fibrosis. We know that fibrosis is reversible with weight loss and other medications, so we're going to counsel him on that. Also, there are some non-modifiable risk factors, unfortunately, with genetics, with PNPLA3, with the 148, that can unfortunately cause some dysregulation in hydrolysis, which can lower your VLDL secretion. We have the MBOAT7 gene, which can increase lipogenesis, decreases the oxidation of fatty acids. And then we have our TM6SF2, which will decrease the VLDL particle size. And unfortunately, all of those combined with a diet high in saturated fats, fructose, which is unfortunately a very typical American diet, will increase that development of steatosis in the liver, which can lead to that inflammation with steatohepatitis, or MASH. And then that unfortunately will lead to fibrosis and scarring in the liver that we call cirrhosis. We also want to think about pandemic causes that significantly increases obesity over the past several years, where we had less physical interaction with people, more stay-at-home jobs working, so that led to more sedentary lifestyles in general. This, of course, increased type 2 diabetes and MASLD increase in the general population. The big elephants in the room that we think, of course, with MASLD is the obesity and type 2 diabetes. Those are the two biggest risk factors that increase the risk of progression to MASH and, unfortunately, cirrhosis in the liver as well. So all of our patients that come to us with these conditions, we really want to be screening them for these conditions. So let's talk about the management of MASH and MASLD. We definitely want to use diet as a key role in mitigating MASH and MASLD, but we have to balance that between making sure that patients are getting adequate nutrients and nourishing their body and maintaining their energy requirements. Central obesity, we think, is one of the major promoters of insulin resistance and type 2 diabetes and pro-inflammatory signaling. So decreasing that central obesity is going to be key. But again, we want to balance that with adequate nutrition. So we bring back our patient, Albert, and we've discussed, or after we've done our non-invasive testing, we've discussed diet and lifestyle with him. He tells us that he has a very traditional Cuban diet. So he eats a lot of rice, beans, pork, corn, beef, and plantains. So not a lot of foods that are really high in fiber, which can help decrease blood sugar and our lipids. Unfortunately, a lot of foods that are high in trans fats. So how do we best discuss diet with patients? This is always a challenge, and specifically in patients like Albert, that his diet is very a traditional Cuban diet. This is not just about having a lazy lifestyle. This is very typical for his culture. So we have to be very sensitive to that, that we don't want to, make him feel like we're recommending to go against his culture and against what his family and his lifestyle typically includes. But we've got to find a way to still improve that diet and tailor it directly for him, still allowing him to have some cultural preferences and still be able to participate in social activities with his family and his cultural group. So, how do we tailor that for him? Well, we really just have to talk to our patients, right? So we want to ask them, how can we maintain the types of culture by getting more of those foods in that we know can improve his trans fats, like and decrease blood sugar, and still be able to allow him to participate in activities. So again, we've diagnosed Albert with MASLD, metabolic dysfunction associated steatotic liver disease. And unfortunately, because his non-invasive testing does not show MASH right now, we're going to talk to him about these lifestyle modifications to improve this fatty liver disease and prevent progression to MASH and cirrhosis. Lifestyle modifications. What do we mean by that? We talk about diet, we talk about physical activity. We know, fortunately, that 5 to 10% of weight loss can actually resolve steatosis in the liver, and in early fibrosis can resolve fibrosis as well. So it actually decreases the anti-fibrotic effects on MASH, decreases the scarring and inflammation in the liver, and has been directly associated with histologic outcomes as well. So when we look and take a piece of the liver, we see reversal of that fibrosis and inflammation. Dietary change and exercise have been the only options that we've had up until the recent approval of resmetirom. So it's still something that we want to be able to recommend to our patients. And as Albert doesn't meet criteria to use resmetirom right now, as he does not have stage 2 or 3 fibrosis, we really want to focus on those typical lifestyle modifications with him today. We know that diet and exercise can be impacted by his genetic polymorphism. So we're going to do our best to try to take a holistic approach in recommending lifestyle modifications for him. So we're going to overcome things like sedentary behaviors and increase aerobic and resistance exercise, as well as try to overcome that typical Western diet and, improve his diet by incorporating more of a Mediterranean diet, which helps with an overall natural anti-inflammatory approach. We do know that high intensity interval training is not as effective as we would like for improvement in overall health for these fatty liver disease patients. And so that's also a significant change from the sedentary lifestyle that he may have now and be difficult to maintain long term. So something that's an easier way to explain and improve his sedentary lifestyle to begin with would be things just like moderate aerobic exercises and resistance. These mild and moderate exercises can help really activate lipolysis, which will decrease fat cells in the liver, and really improve his resistance exercise will improve his muscle and which will naturally decrease burn calories and improve his lipolysis as well. It also requires less energy consumption than that high intensity interval training. So it's much easier for our patients to get involved with, especially when they're coming from a sedentary lifestyle. We also do want to talk about calorie restriction. So that doesn't mean that we're putting him on 1,000 calorie a day diet, but we want to look at his overall diet now and find ways that we can restrict that while still maintaining adequate protein intake and maintaining blood sugars. As we reduce calories, typically by about 10% is what we'll see with the weight loss, is that's going to be our goal. And that will help promote with ketogenesis as well, which decreases the blood sugar and will hopefully overcome some of those genetic predispositions that we spoke about earlier that may cause some, lack of response to other diets. Although we know Mediterranean diet is supported by the AASLD and the European guidelines, we do know it can be difficult. So we really want to counsel him on making maybe some overall changes moving towards that, which may be difficult to do overnight, but it is definitely the primary interventions that we're really going to talk about with him, as well as the exercise increase. So Albert returns to us and as about 6 months, and he's got no change in his labs, unfortunately. He does admit to us that he hasn't begun any exercise regimen, but he has been trying to cut out his soda. So how are we going to work with him to create behavior change? There is a scale that we can use called an exercise and diet adherence scale. It's voluntary, so I will typically give this to our patients at the first visit after we've made the diagnosis of MASLD, and encourage them to use this to track their improvement over time. We'll get it at baseline and do it every 6 months. And it has 33 criteria to kind of check their monitor daily exercise and calorie intake. So it's pretty extensive, but again, it's voluntary. So in a situation like this, it might be the tool that Albert needs to really help motivate him because he can see his own scoring system from the beginning and after he's slowly made changes over time. So I encourage all of you to continue to participate in our GAP MASLD MASH Community Network, where we're going to continue to have local webinars or small webinars to discuss these topics as it relates to our patients out in the community with high prevalence of MASLD and MASH here. And I encourage you to use non-invasive testing as well as have other recommendations to have the best resources for your patients, encourage screening on a regular basis, and share in the knowledge with your colleagues so that we can make sure that we're getting testing regular for these patients and not hopefully prevent progression to MASH and cirrhosis in the future. Thank you guys for joining so much.